Good afternoon, Rajesh sir.
Hello. Hi, Vinith.
Hello, sir.
All well?
Yes, sir, absolutely.
Good.
We can start now.
Okay. So, on behalf of IAP Pune, I welcome you all to this 7th session of IAP PG case presentation. Today, we have Dr. Sailusha, who is a junior resident 3 at PG Medical College, Pune, and her mentor is Dr. Pragati Kamath. We have esteemed faculty today, Dr. Sampada Tamolkar, Madam from DY Patil, and Dr. Vinith Wankede, pediatric neurologist from Nagpur, and he is an ex-BJite. We are very proud that we have him as a faculty here. I think without wasting much time, let us start with the case presentation. Dr. Sarusha, over to you.
Good afternoon to all esteemed faculty. I am Dr. Sailusha Vadapalli, third year resident from BJ Government Medical College and Sassoon Hospital. I will be presenting a case of neuro case, CNS case. My case is Kumail Sheikh, a 8-year-old male child who is firstborn of 2 children, born of a 3rd-degree consanguineous marriage, born to a Muslim family, resident of Pune, Ghodpadipet, hailing from Pune. The history was obtained from both his parents. The history is adequate and reliable. The child was brought to the OPD with history of weakness of right side of his body since 4 days before the admission. The child has been admitted since today. It is the 13th day of his illness and 9 days since the onset of his complaints. The child was brought to the OPD for a scheduled prescription that he had been recently started on for a neurological infection, according to the mother. When the mother reported these complaints, the child was admitted from the OPD. I would like to start the onset duration of progress of my history from 4 months prior to today. That was the time when the child was absolutely all right. 4 months back, the child was brought with history of high-grade fever, which lasted 4 days and altered sensorium for 1 day, after which he developed tightening of all 4 limbs and uprolling of eyeballs. The child was brought to the hospital in a drowsy state. At that admission, the child was diagnosed as a case of tubercular meningitis and was started on anti-tubercular treatment and was discharged. During the same admission, the child underwent a surgery in which a shunt was placed on the right side, a ventriculoperitoneal shunt. 4 days later, after getting discharged, the child was brought back with history of vomiting, nausea, and abdominal pain and brownish colored vomitus. At this point, the child was admitted again, and the mother gives history that she was informed that there was damage to his liver because of the anti-tubercular treatment. The child was given alternative anti-tubercular drugs, and the original drugs were reintroduced one by one after documenting his liver tests. And when the child tolerated all his anti-tubercular drugs, he was then again discharged. Till 4 days before his current admission, the child was well at home, taking his treatment well, and had no further complaints. 4 days prior to his current admission, he developed weakness of the right side of the body, which was noticed in both the right-sided upper limb and lower limb at the same time. The weakness was more prominently seen in the right upper limb than the right lower limb. It was noticed by the mother during the routine morning physiotherapy. The child had gone to bed uneventfully the previous night and had woken up normally. The weakness was insidious in onset, gradually progressing over 4 days when the child was at home. The child had to use his left upper limb to lift his right upper limb to be able to feed himself. The child had weakness of his lower limb, which could not, due to which he could not walk on his own. He had to take support. The child could not get up from lying down position to sitting position without turning to his better side, that is the left side, and taking support of his left upper limb to pull him up to the sitting position. The child had difficulty in raising his hand above his head, although he was able to grasp objects in his right hand. However, the mother complains that the child could not hold a pencil to be able to write. Also, the grip in his right hand was less than the grip in his left hand. The child was unable to walk without support, but was able to put on his slippers without having to use his hands or the upper limb. The mother gives history of gradual worsening of these symptoms at home over 4 days, at which the mother had brought the child to the OPD. The child has been admitted since the last 8 days, and there has been marked improvement since his admission. Now the child is again able to raise the hand overhead, and he's able to comb his hair. He's able to feed himself with his right hand. He's able to write legible alphabets. He's able to walk without support. He gets up from supine to sitting position, from squatting to standing position on his own without any assistance. There has been no history of any altered sensorium, convulsions, or memory loss or inappropriate behavior. No fever, headache, vomiting, or blurring of vision. There is no loss of sensations in his upper or lower limbs. The child is able to feel the sensation of clothes on his body and slippers on his feet. There is no change of smell or taste perception, no diminished vision or reduced movement of eyeballs, no difficulty in chewing or swallowing of food, no regurgitation, no facial deviation, no drooling of saliva or inability to close eyes, no change in voice, no involuntary movements or urinary complaints. His past history and drug history, as I had mentioned earlier, the child was diagnosed as a case of tubercular meningitis 4 months back. The infection was diagnosed on a CSF report, and the parents give history that they were told that the organism is drug sensitive on the report. He was started on anti-tubercular treatment in February 2022. In the same first admission, the child had to be operated with a VP shunt, which was placed on the right side. The child took anti-tubercular treatment for 3 weeks, was well at home. When he presented back with nausea and vomiting and had to be admitted again, at which the mother was told that the liver function had gone down because of the anti-tubercular treatment. His first line, the drugs that he was taking were withheld and alternative drugs were given, after which every week one drug was added. The child was admitted for 4 weeks in the second admission. He was discharged only after he was tolerating his treatment well, and there were no further complaints. Since then, the child has been at home and has been taking his treatment continuously, following up in the tuberculosis OPD and taking his regular prescriptions. Currently, the child is on continuation phase of his anti-tubercular treatment, the second month of continuation phase. At home, the mother reports no episodes of fever or any repeat episodes of nausea or vomiting. The child has documented weight gain from his tubercular OPD record.
Sailusha, can I just interrupt you? You finished telling us the history, right? Your ODP is done, right?
Yes.
So can you just let me know what exactly at the end of the OPD do you feel this is about? What is your interpretation after the ODP?
Ma'am, it is a 8-year-old male child who is a diagnosed case of tubercular meningitis, who has come with right-sided weakness of the upper limb more affected than the lower limb. His proximal muscles involved more than his distal muscles. What
makes you feel the upper limb is more affected than the lower limb? Because in the opening, if you could just go back to the slides, you mentioned that both the upper and the lower limbs were equally affected. If you could just go back. Yeah, weakness. Yeah, one second.
Ma'am,
weakness noticed in both upper and lower limbs simultaneously. Okay, sorry. Weakness noticed more in the right upper limb. So how did you ask for weakness being more in the upper limb than the lower limb? What history did you actually ask?
Ma'am, the mother gives history that the child is able to walk with some kind of support, but the child is unable to lift his right arm even to be able to feed himself or lift his arm overhead.
Okay. So at the beginning of your history, Shailusha, did you mention the handedness of the child in the opening statement? If you go back to your opening statement, 8-year-old, I think in a case of hemiplegia, it's a good idea to give the handedness of the child, because that would invite questions as to handedness, and you all are generally prepared with questions on handedness. By what age is handedness established?
3 years, ma'am.
Handed is established at the age of 3 years. When does it manifest? When is it established in the brain? When is it manifest? Until what age can you change it?
It is established at 1 to 1.5 years of age, manifests at 3 years, and can be changed up to 5 years of age.
Oh, yes, you can change it up to 6 to 8 years of age for that matter. Okay, now if you do not, that we can ask in your examination also. If you do not, if the child cannot write, are there any ways of knowing the handedness? Supposing a child is amputated, can you actually know the handedness of the child without having to use the arms and the legs? Think about it. Which organ can be used to show the handedness of an individual? I'll give you a hint. Your mind does not know what your eyes do not see. Can you take the hint?
Ma'am, the child can be shown an object in his field of vision. With his eyes closed, an object can be placed in his field of vision. The first direction in which he looks after opening his eyes is probably his handedness.
No, you just roll an X-ray and ask the child to look through the X-ray. The handedness will be decided by which eye is he looking at through the X-ray hole. Is that clear?
Yes, ma'am.
Okay, so that is one. So according to you, the upper and the lower limb were affected simultaneously. Did the parents actually tell you one by one the TB medications were stopped and started? Did they really give you this history in detail?
Yes, ma'am. I had asked them when the previous time the child had to be admitted, what exactly was done, because they had been told that the liver had gone bad. The mother had said all the medications that he was on were all changed. She was receiving 2 tablets. She had said that 3 of his medications were in 1 tablet and 1 tablet was separate. All the 4 were withheld. 1 tablet was continued, and the combination of 3 drugs was stopped, and 2 other medications were started.
If there was a grandmother and she did not know which medications were stopped and which medications were started, is there any way of knowing what was probably stopped?
Ma'am, we can know that rifampicin was stopped because it causes an orangish discoloration of his body fluids and urine.
Yes.
History,
Yes.
the parents would give.
Yes. And another thing in your history, you said that he was lifting his right upper limb with his left limb, and he was eating with the right hand. Is that the history?
Yes, ma'am.
So he was using the distal part as well as the proximal part?
He could not bring up his...
See, normally if a child who cannot use the right upper limb, he's a right-handed child, he would use the left hand to eat, right?
Yes, ma'am.
The fact that he was holding his right hand with his left hand, he was making an attempt to eat with the right hand. That means the weakness was more in the proximal part than the distal part.
Yes, ma'am.
So do you expect this kind of a picture in any hemiplegia? Where is the most affected? Which is the most affected part? Because that is something which will not fit into a case of hemiplegia. Distal, I mean, proximal more affected than distal weakness.
Ma'am, the most common point of affection in case of hemiparesis is the subcortical region, the internal capsule.
What do you think, according to your history? This is a dense hemiplegia, right? Both upper and lower limbs got affected at the same time, right?
Yes, ma'am.
So according to you, which part from the history alone would be affected if it is a dense hemiplegia?
From this history, the lesion is certainly at a subcortical level because the higher functions are not affected. There is no inappropriate behavior or social inhibition.
Any other indications where the cortex is not affected? You said higher mental functions are unaffected. You said that behavioral changes were not there. Any other history which tells you that higher functions are unaffected? I mean, the cortex is unaffected?
Ma'am, there is no altered sensorium. There have been no convulsions.
Correct. Very good. What else? What else? Which are the different cortices?
There is the sensory cortex and the motor cortex. There is
that is one part. You did mention about sensory also. What about the special senses? Which special senses history? You've already taken that history, dear.
There is occipital cortex in which the vision centers are located. The child doesn't have any blurring of vision or diplopia or any visual complaints, a reduced field of vision.
So do you feel that there is diplopia when the occipital cortex is affected?
No, ma'am. It is affected more in the affection of the extraocular muscles.
So in cortical level involvement, involving the occipital lobe, there would be blindness, right?
Yes, ma'am.
Okay, fine. So I think Mankere said you want to ask something.
So I agree with you, but what is your likely localization, like on history, on anatomical localization? Like suppose if you what is your probable diagnosis on history?
Sir, the likely anatomical location is at the subcortical level, not involving the internal capsule completely, because the affection is not involving the complete upper or the lower limb. There is some there is some sparing of the distal muscles of both upper and lower limbs. Maybe
they are less affected. They are not spared.
Sorry,
I think it's
they are less affected than the proximal groups.
That is about the from surface to the deep. What about the AC, MC, and PC territory? What you feel that it is likely to be a posterior circulation territory, or it's middle
circulation?
History can
cerebral
just middle cerebral. Why? What are the pointers for middle cerebral?
Sir, anterior cerebral artery supplies the frontal and temporal cortices. It would essentially cause cortical involvement, which is not seen in this case. There is no loss of higher function and no social inhibition. Posterior cerebral artery supplies to the hindbrain and cerebellum. There is no incoordination of movements or loss of balance in this child, unlikely that the midbrain and cerebellum are affected. And the area of affection in this child is the limb muscles during around the level of internal capsule, but not involving it completely.
But Sailusha, can you just explain?
Localization is the bladder and bowel, so it's not like the frontal and temporal strictly. You just go through the. You can read about the vascular territories, and if you draw as a brain, then the anterior 1/3 is supplied by your ACA. Then the middle part, almost 2/3 is supplied by your MCA, and posterior down the line you have PCA. So the major area of the lateral surface of the brain is supplied by your MCA. So if you have bladder sparing, if your loss of involvement is your high functions are not affected, very likely that you have MCA territory. Then your MCA comes your motor cortex and your premotor areas. So here is very likely to be an MCA territory. So as you are truly said in your history as well, there's no affection of bladder and bowel. So that again supports your hypothesis. So one thing is your territorial distribution. Does your area of involvement follows a territorial distribution? And another is whether it's a cortical, subcortical, basal ganglia, that way. So both way you can figure it out on your history, and the listener should get an idea from your history that you are local. You want to try to localize your lesion to that part. So that should begin from history. You have beautifully narrated. I'm okay with that. But I think there are the few points which are essential while presenting.
And also, sir, if I may add, when you're saying, Shailusha, you're talking about subcortical involvement, generally, there is a fanning of the fibers in the subcortex.
Yeah.
So if you have such a huge involvement, that means upper and lower limbs affected, may not be of the same degree. But if you have both the limbs affected, there is less likely to be a subcortical involvement, more likely to be an internal capsule related. Second thing is in your distribution, MCA, ACA territory is one thing, but also involvement of the other regions of the brain, and of course, most important in acquired hemiplegias, talking about cranial nerve involvement would be extremely important. I don't know, I can't recollect if you've given a detailed analysis of facial asymmetry or the other cranial nerves. Have you given it in your history, negative history?
She has mentioned few things.
Yeah, you have. So it has to be highlighted. Okay?
Yes, ma'am.
All right. Okay. Go ahead.
The child has a normal birth history. He was born at full term through a normal vaginal delivery with a birth weight of 2,600 grams. The child had cried at birth and required no NICU care. He's completely immunized till 5 years of age. The child has received BCG at birth. There is a scar present on his left shoulder. The child goes to third standard, has good scholastic performance. He's a developmentally normal child. He consumes a mixed diet with a calorie deficit of 320 calories and a protein deficit of 5.6 grams. He is born to a family which is a nuclear family containing the parents and children. The parents are a third degree consanguineous union. There is no history of a similar illness in the family. There is no history of contact with any person diagnosed with tuberculosis, or any person with a long debilitating illness, or any person who's died of such a condition. Both the parents and the child's younger sister have been screened for tuberculosis. All have been tested negative. The younger sister, who's 1 year old, is on isoniazid prophylaxis treatment. The family belongs to modified Kupuswami class 2, which is upper middle class. They are residents of an urban area of a pakka house with adequate sanitary facilities. I would like
if
to...
I may ask, Shailusha, what are the risk factors for tuberculosis in this child who has landed in tuberculous meningitis straight away? What are the positive risk factors for TB in this child?
Ma'am, this child, there is no history of overcrowding in his family. The child is undernourished. He has a nutritional and calorie deficit.
Why is he undernourished? That is my question. He is born to engineer parents, good Kupuswami classification, eating well, a nuclear family, a good size house. Why do you think this child has not eaten well? His calorie deficit is great, his massive, protein deficit is massive. He's been given a BCG, a scar is present. Why did he land up in tuberculous meningitis? Are there any pointers? So what I'm trying to say, are there any etiological diagnosis in your history besides tuberculosis? Do you attribute everything in this history of hemiplegia to tuberculosis? Are there any differentials? That's what I'm trying to ask.
I'm sorry, ma'am. I am not able to think of a differential because before his.
Okay, so let's put it in a different way. If there is no history of tuberculosis in the family, forget if there was a grandmother who did not give you a history of tuberculosis in this child, what differentials would you have thought of in a child with hemiplasia? Simply put.
It could be an intracranial bleed or a sudden thrombosis or an embolic episode.
So could you just clinically tell me the difference between thrombotic, embolic and a hemorrhagic stroke with respect to the onset, the progression, the consciousness?
A hemorrhagic stroke would be an extremely acute onset
which is
event.
the most extreme acute onset is hemorrhagic or something else?
It is embolic,
Okay,
hemorrhagic, and
very
then
good.
thrombotic.
Yeah. So that is with regards to the onset. Something else? What happens to the consciousness?
Consciousness is altered in embolic and hemorrhagic strokes, not so affected in a thrombotic stroke.
Are there any histories of TIs which has been given previously?
No, ma'am.
No history of TI in the past.
TI in the past.
So do you think this stroke is because of tuberculosis or is it because of the treatment which has gone wrong right now? You've shunted the child and something has gone wrong with the shunt, or is it because of the primary TB? So what are you looking at?
It could be because of tuberculomas that have appeared in his parenchyma. It could be an immune reconstitution.
A tuberculoma will give rise to such a deep insult? What is your first diagnosis? Is it a tuberculoma? Is it a vasculitis? Is it obstructive hydrocephalus? Or is it a bleeding because of the hepatic failure? What is it?
It could be it is certainly not an obstructive hydrocephalus, man, because there is no history which is suggestive of a sudden onset headache or projectile vomiting at the current presentation. There is also no history of nausea and vomiting, or the child had presented with brownish colored vomiting after a period of nausea and vomiting in his previous admission when he was diagnosed to have antitubercular treatment associated liver injury. Such a history is also not present here, ma'am.
So there's history of hematemesis also, no? Right now you said there's bloodstained vomitus abdominal. There's no history.
Not in this. There is no such history in the current admission. This time the child was brought to the OPD for his routine refill prescription of his antitubercular treatment. The mother had, as a passing remark, said that he has developed a weakness of his right side of the body since the last 4 days before when he was brought. He was admitted from an OPD visit.
Okay, fine. Go with the general examination.
Anthropometry, the child is 15 kgs, which is less than -3 standard deviations for his age. His height is 105 centimeters, which is also less than -3 standard deviations for his age. The child is both wasted and stunted. However, his BMI at 13.6 is just over -2 standard deviations. He is on the brink of being called malnourished. General examination, the child was examined in adequate exposure in daylight in the mother's presence. He was awake, alert, and taking instructions. He was communicative.
Dr. Sailusha, I want to ask you something. May I ask you something?
Yes, sir.
You said the height is 105 centimeters. At what age will you get a height of 105 centimeters?
So the child reaches around 100 centimeters of height at 5 to 6 years of age.
No. No, Shailusha. At what age does a child reach 100 centimeters? Is it at 5 to 6 years of age? You're reading your IAP, your charts, no? The
You have a
centigrade growth
formula
chart.
also, no? If you
You have
can't
a
remember
formula.
offhand, use the formula.
What's the formula, Shailusha?
I'm sorry,
You
ma'am.
can look into your charts and answer.
Dr. Rajesh has been your undergraduate teacher as well, right? Rajesh, you know exactly what she doesn't know.
JR3 will not know anthropometry because
This
this
is
is
a common
done by
problem.
the
Yeah,
intern.
for exam going
And
students, it's a problem.
yeah,
They know
it's a
everything but
problem.
anthropometry.
And they
Because
can't
stop taking
interpret that.
anthropometry.
And they stop interpreting it as well. So,
Yeah.
okay. So
Why
the
I was
point
asking
is,
you is because, when you check the height and weight of the child, you can get a pointer towards when the disease process has started.
can you tell
Okay.
us from this history, wasting and stunting, what does each mean, Sailusha? What does wasting mean in clinical terms, and what does stunting mean?
Stunting in clinical terms means that the nutrition of the child has been poor over a chronic period of time.
Okay.
Wasting implies that the nutrition has been inadequate in recent times.
Yeah, and this child is both stunted and wasted, right?
Yes, ma'am.
So why did you say he's just below centiles for malnourished? He is malnourished, right? If there is failure to thrive, right?
Yes, ma'am. Yes, ma'am.
Okay. Go ahead.
The child was examined in the mother's presence. He is active, he is awake, alert, taking instructions, and communicative. His pulse rate is 98 per minute, regular, of normal volume. Pulses were symmetrically felt, and all peripheral pulses were appreciated. His respiratory rate was 22 breaths per minute, quiet abdominothoracic respiration. His blood pressure was 102 on 54 millimeters of mercury, which is 5th to 50th centile, taken in the right brachial artery in supine position. His saturation is 98% on room air. There is no pallor or edema, clubbing, icterus, cyanosis, or any lymphadenopathy. On head-to-toe examination, there are no stigmata of tuberculosis seen. The
Can you name
ventriculoperitoneal
some? Can you name some?
matted lymph nodes, scrophulodema, erythema nodosum, flick tenular conjunctivitis, a beaded vas deferens in a male child,
Hmm.
a
Why
positive
do they
1 to
occur?
10.
Why do they occur?
They occur due to granulomatous inflammation due to the tubercular bacilli getting deposited in these tissues, ma'am.
All of them? The skin changes? The hair changes?
Ma'am, the hair changes and skin changes occur due to the chronic wasted condition of the child.
So what does it cause? Correct, you're right, the track is right. So if you have chronic stress, what is elevated?
There is elevation of corticosteroid levels
Yeah,
in
cortisol. Good, go ahead. How did you check for the VP shunt patency? Did you do the VP shunt patency?
Ma'am, the chamber which is palpable behind the right pinna is compressible without any pain or injury.
How do you know if there is a block, Sailusha? How do you know that the upper end is blocked and the lower end is blocked? You have a VP shunt in place, right? In C2, you have a chamber. And you have a shunt which is palpable. So how do you look for the upper end blockage and the lower end blockage? Because in exams, they will ask you to check the patency.
Sorry, ma'am.
So you'll have to first empty and you'll have to look at from where, which end the filling up is happening, right?
Yes.
Okay. All right. Go ahead.
Systemic examination. The child is conscious, oriented to time, place, and person. Memory is intact. The speech is fluent, coherent, meaningful, and clear. Comprehension.
Did you do the Macevan sign? General examination. Did you do the Macevan sign? Did you look for signs of? There is something called a system-specific general examination, right? You started with the systemic examination. Did you do the system-specific general examination of CNS in this child? Did you look for signs of meningeal irritation?
Yes, ma'am. I have mentioned them.
You've mentioned them in the systemic examination?
Yes, ma'am. They are mentioned.
But why so in where will you put it in the systemic examination?
Ma'am, signs of raised intracranial pressure and signs of
but
meningeal irritation.
What are the signs of raised ICP?
Headache, blurring of vision.
No, I'm saying signs, not symptoms. Signs. What are the signs of raised ICP? What is Cushing's triad?
There is hypertension, bradycardia, and altered sensorium.
Yeah, so these you care to put them in the general examination or the systemic examination?
Ma'am, on his in his general examination, his sensorium is intact. There is no bradycardia and there is no hypertension.
Okay. What else? That's why I'm asking you. What is Macevan sign? What is crackpot resonance? What will happen when you tap on the prominences parietal frontal and auscultate, or you can hear it with your ear?
There could be a bruit in case of raised intracranial.
Bruit in raised ICT. Where do you get bruits? Do you get bruits in raised ICTs?
No, ma'am. They are seen in arteriovenous malformation.
AV malformations, right? So in Macevan sign, you get them in raised ICT, which is called as crackpot resonance. In children less than 1.5 years, you're not supposed to do it because what is open?
The anterior fontanelle is open.
So you're not supposed to do it. So never forget to mention these signs on doing CNS general examinations. So which is the three things which you're generally supposed to do. One is Macevan's raised ICT, second is meningeal irritation, and the third important thing is, maybe not in this case, but otherwise in cerebral palsy, etc., would be a neurocutaneous markers. These are three things which you have to mention in your general examination, whether we like it or no. Okay?
Yes.
Okay. Sailusha, just one question. This child has undergone a VP shunt. Will it affect the Macevan sign?
If the shunt is intact and patent, then the Macevan sign should be normal.
Now, what is the basic, why ma'am is asking you this question is because what is the basic physiology or pathophysiology behind the Macevan sign?
Ma'am, the external jugular is blocked if there is raised, if there is impaired CSF flow, if there is any tendency of developing an obstructed hydrocephalus, then the Macevan sign would come positive.
No, I think just go read about it, Shailusha. Okay? Okay, systemic
Just
examination.
remember the pot has to be intact for it to crack. And then you will get the sign. Okay, so you do little homework about Macevan sign. Nowadays, you people have a CT scan available with you. Before I come for the round, you already have a CT scan. So there is no need to do the Macevans. Okay, all this bedside neurology has gone away. And that is the big problem. So you will read it and you will maybe next PGP, you will tell it to the others. Read it in detail. Okay.
And Cushing's triad is not, she said, altered sensorium. It's not altered sensorium, it's irregular respiration.
It's bradycardia or other irregular respiration,
bradycardia,
and
hypertension. Irregular
hypertension.
respiration. Yeah.
Okay. Fine. Go ahead, systemic.
His cranial nerves were examined and they are all normal. There is preserved sense of olfaction. There is no normal visual acuity, field of vision. Pupillary reflexes are normal. No external ophthalmoplegia. All extraocular muscle movements are preserved. There is no drooping of eyelids or ptosis. There is preserved sensations on the face, normal movements of the muscles of mastication. No facial deviation or drooling of saliva. The hearing is preserved. The gag reflex is present and normal palatal movements are seen. The tongue movements are normal. The child is able to shrug his shoulder and has normal movements of his neck. In motor system examination,
you spoke about
the
fundus, no? Yeah? Fundus has been written?
Yes, ma'am.
Sorry, I missed it.
In motor system examination, the posture of the child was examined in his lying down position. The right upper limb was lying by the side of his body. Right lower limb abducted, externally rotated. Left upper and lower limbs are seen in neutral position. When the child was asked to walk, the gait is a circumduction gait in which the child rotates his lower limb in order to be able to place it ahead of his limb, his right limb. Nutrition of his lower limbs. Bilateral upper and lower limbs are generally wasted. The tone, there is right-sided hypotonia, which is more so in the upper limb than in the lower limb. This is tested by passive. Yes, ma'am.
Okay. Okay, go ahead. We'll discuss it later.
The power was tested at all joints. At the shoulder joint on the right side, there is reduced power. Flexion, abduction, and lateral rotation affected more than extension, adduction, and medial rotation. The power is more affected in the shoulder and progressively better in the elbow and wrist joints, and it is best in the small muscles of the hand. The left-sided upper limb has normal power. The child is able to conduct all movements against resistance. In his lower limb, again, the hip is more affected than the knee, and the foot is least affected. The left lower limb has normal power, all movements possible against resistance and against gravity. Deep tendon reflexes were elicited, which were brisk on the right side and normally elicited on the left side. Superficial reflexes were elicitable all normally. The plantar reflex is extensor on the right side and flexor on the left side. There is no clonus. There is no sensory involvement. Touch, pain, temperature, joint sense, and vibration sense are intact. The coordination could not be tested, ma'am, due to significant affection of the upper limbs, in which the proximal muscles had power less than 3. There is no urinary incontinence or retention. There are no signs of meningeal irritation. There are no signs of raised intracranial pressure. The fundus examination is normal. In his other systems, the cardiovascular system, S1 and S2 are heard normal. There is no murmur heard. In the respiratory system, air entry is bilaterally equal in all lung fields. No adventitious sounds are heard. On his abdomen, the abdomen is soft and there is no tenderness. There is a surgical scar seen in the right lumbar region, 4 centimeters superolateral to the umbilicus. There is no organomegaly. Liver and spleen could not be palpated.
Liver is also not palpated?
No, ma'am.
Okay. So you're done with the systemic examination?
Yes, ma'am.
What are the ways in which you can test the tone?
Tone can be tested by passive movements of the limbs at various joints, or it can be also.
Will you start with inspection? Posture?
Yes, ma'am. Reduced tone, the limbs would be lying by the side of the body. They appear flabbier than a muscle with good tone. On palpation also, a muscle with normal tone is stiffer than a muscle with reduced tone. During palpation,
it is stiffer or it is firmer? There is a difference between stiff and firm.
Yes, sir.
It will be hypertonia.
Yes, sir.
Yeah, so normal muscle is firm to feel. It is not stiff.
So what was this? The muscle was flabby on palpation? You said there was hypotonia?
Yes, ma'am. The muscles were flabby and the muscles were flabby and passive movements could be conducted very easily compared to the left-sided limbs, in which
so what
there was
happened
some
to the
resistance.
range of movements?
Range of movements were increased on the right side, more so in the proximal muscles than in the distal muscles.
So do you expect this in a case of hemiplegia? You said that the problem was in the MCA territory. It was a subcortical involvement. So what do you expect normally?
Normally, in a subcortical involvement, it is a upper motor neuron kind of lesion, in which there is hypertonia, hyperreflexia, and hypotonia is a lower muscle, lower motor neuron sign.
So why do you think there is hypotonia here?
Ma'am, it could be due to ma'am, this child is a known case of tuberculosis. If the pathophysiology behind his condition is a tuberculoma or the iris syndrome, immune reconstitution, it could be multiple lesions in his cortex. And if the cerebellum is involved, that explains the hypotonia.
If the cerebellum was involved, what else he should have?
There would be incoordination of movements, ma'am.
Will there be nystagmus or no?
Will your hypotonia be asymmetric in cerebellar lesion?
You said if there is cerebellar involvement, there should be bilateral hypotonia. Why is there unilateral hypotonia? Why will only one lobe be affected? Have you heard of something called as spinal shock, neuronal shock? What is that?
Yes, ma'am. It is due to injury to the spinal cord, the anterior horn cells of the spinal cord. However, in
Is
that
it due
case,
to the injury in the anterior horn cells? Anterior horn cells is a part of LMN or UMN?
Polio is LMN or UMN? Sailusha, is polio upper motor neuron or lower motor neuron?
It is lower motor neurons.
Yes.
Then what is affected in polio? What part of CNS is affected?
The spinal, the anterior horn cell of the spinal cord. Sir.
Correct.
Okay, let's just reframe the question. Shalisha, can you tell me causes of hypotonia? Hypotonia. One you said is element. Okay, agreed. What are the other causes of hypotonia?
Cerebellar disorders causing, but hypotonia would be bilateral and cerebral.
Cerebellar causes can cause hypotonia, accepted. Any other cause? Any subcortical gray matter involvement can cause hypotonia? Can happen. Child can have rheumatic fever. In general, I'm asking you causes of hypotonia, not in this case in particular. Can chorea cause hypotonia?
Yes, ma'am. In cases of rheumatic fever, it is specifically called Syndenham's chorea.
Yeah, so it can cause hypotonia. Any fourth cause which may be present in this child? Will you read about it? Neuronal shock or spinal shock? Okay.
Yes, ma'am.
All right. So you feel, so what do you think this is? A UMN problem or an LMN problem? In this case?
Ma'am, this looks like a UMN problem because there are brisk reflexes. The right-sided plantar is upgoing extensor plantar. There is involvement of major groups of muscles, and there is no sensory involvement which would go higher in favor of a spinal etiology. Also, we would get a definite sensory level in spinal involvement. There would be bladder involvement in if it is a spinal cause, or
okay, so you feel this is an upper motor neuron with hypotonia, right? That's what you feel?
Yes, ma'am.
Okay, so what do you think is the cause of this? Is it symmetrical? Is it patchy? Is it extensive? Is it non-extensive? What kind of involvement is there?
It is an extensive involvement of the right-sided upper and lower limbs, involving the proximal muscles more than the distal muscles. It is it was a progressive lesion.
What do you think is the level? Sir has already asked you this question, but repeat the answer.
The level is, I would still put it at a subcortical level, ma'am, because of the lack of involvement of cranial nerves, which places it above the brainstem and near the territory of the internal capsule, because of the dense involvement of proximal and distal muscles of one side.
What are the hallmarks of internal capsule hemiplegia? 4 hallmarks.
It is a dense hemiplegia with upper motor neuron
Hemiplegia is
deficit.
upper motor. Yeah.
It is I want to read it up now.
Okay, so just give us a diagnosis. You give us the anatomical, physiological, etiological, diagnosis, complications in this case, the diagnosis.
It is a 8-year-old male child with right-sided hemiparesis involving proximal muscles more than the distal muscles, without higher function cranial nerve sensory or autonomic involvement. In a diagnosed case of drug-sensitive tubercular meningitis with a ventriculoperitoneal shunt in situ and functional, likely of an upper motor neuron lesion at a subcortical level, most likely due to an immune-mediated vasculitic etiology, which could be a post anti-tubercular treatment immune reconstitution syndrome, or could be a tuberculoma, or it could have been due to drug-resistant tuberculosis causing fresh lesions in his brain parenchyma.
Okay, why do you think this is vasculitis?
And vasculitis is one very frequently associated with tubercular pathophysiology. Hallmarks of vasculitis is a sudden onset, progressive focal deficit, and it responds rapidly to treatment. Deficit.
How is a deficit? Is it very symmetrical? Is it very patchy?
It is a patchy involvement, ma'am.
So it's an asymmetrical patchy involvement. The left limb is not involved at all?
No, ma'am.
Left limb not involved at all? Okay. And no cranial nerves also?
No, ma'am.
Okay. So for the revision of other PGs, what are the other causes of, supposing this child gets hemiplegia again after 2 months, what are the possibilities of recurrent hemiplegia? What are the etiological factors for recurrent hemiplegia?
It could be a child with tendency for thrombosis. Thrombotic strokes can occur in different
etiology conditions, causes of thrombotic strokes.
Hypercoagulable states like nephrotic syndrome, protein C, protein S deficiencies, sickle cell disease causing microthrombi.
Go system wise, no? Classify system wise. So if you've taken the hematological, finish the hematological group. You've taken sickle cell. What else? In the red blood cells?
Polycythemia.
Yes.
Any hematological malignancy which can lead to secondaries.
Okay. Then cardiovascular.
Any acyanotic heart disease with a persistent foramen ovale, which can lead to condition leading paradoxical embolism, leading to
cyanotic or acyanotic? More common?
More common in cyanotic heart disease.
What age group? Age group, less than 2 years, what is common? More than 2 years, what is common? In cyanotic heart diseases, less than 2 years, what is more common? And more than 2 years, what is common? Complications? thrombotic strokes are common in? Thromboembolic strokes are common in less than 2 years of age.
2 years
Okay.
of age.
And more than 2 years, what is more common in cyanotic heart diseases? Brain abscess.
Abscesses.
Okay. All right. Any other cause? Can this be COVID? What I'm trying to ask you for a very long time. Why can't this be a post-COVID complication? Part of MISC? Have you asked for history of COVID in the family? Because there's been MISC cases again we are getting. Why can't this be MISC? Why are we sticking to tuberculosis as a diagnosis? That is what I was asking you for a long time.
Ma'am, for post-COVID MISC, there has to be this child doesn't give history of a fever.
No, many of the kids have not had any history of fever and they have had IgG positive, very high levels of immunoglobulins. Why can't this be a COVID brain? And they have come to us with strokes, right? You can't rule it out. What I'm trying to say is that when you know the diagnosis in the exam, you can't stick to that diagnosis. You will have to give a differential diagnosis. You cannot say it has to be a post-tubercular complication. Okay? So please keep that in mind as well. Okay?
Yes.
Now, just coming to it, this is an 8-year-old child with a very acute history. Supposing this was a 2-year-old child with a history of hemiplegia, how do you differentiate hemiplegic CP from an acute infantile hemiplegia? Acquired hemiplegia or hemiplegic CP, right? Antar kya hai? Clinically, how will you differentiate?
Acquired hemiplegia, the child would be developmentally normal, whereas hemiplegic CP would have developmental delay.
Hemiplegic CPs will have will it be like a global developmental delay?
Not necessarily, ma'am, but since at the point of presentation, hemiplegic CP is unlikely to be completely developmentally normal, whereas an acquired hemiplegia can occur in a child who's till that point developmentally normal.
Okay, accepted. So one thing is about development. Second, looking at the position, posture.
Most common variety of cerebral palsy is spastic cerebral palsy.
No, I'm not asking you CP at all. I'm asking you a simple question. What is the difference? How will you clinically make out if this is a hemiplegic CP or this is an acquired hemiplegia?
Ma'am, there would be a significant birth history also. There has to be a history.
That is accepted. Every time you may not get a significant birth history. I'm talking about you'd have the child in front of you on inspection, palpation, looking at the child. How do you know this is acquired or this is congenital? What has happened to the lower limb in your child? What is the position of the lower limb in your child?
In this patient, it is it is abducted and laterally rotated.
Yeah, so externally rotated and abducted, right? What happens to a child with congenital hemiplegia to the lower limb?
It is adducted and internally rotated.
Excellent. So that is one difference. Second, are there any cranial nerve involvement in this child? You don't have. What is generally common? Which cranial nerve is generally commonly affected in acquired hemiplegia?
The sixth nerve.
No, in acquired hemiplegia, which is the commonest affection? Seventh nerve, right? Yeah, spatial nerve involvement is extremely common in acquired hemiplegia. It is generally not seen in congenital hemiplegia. What about the 3, 4, 6? You just
extraocular. In this child, they are normal.
Yeah, but what happens in a congenital hemiplegia? 3, 4, 6 can be affected, right? Which sex is predominantly affected in congenital hemiplegia?
Male sex.
Male sex is more affected in congenital hemiplegia. Is there any sex predilection in acquired hemiplegia?
No, ma'am.
No. Is there any phase of spinal shock in congenital hemiplegia which is not there in acquired, which can be there in acquired hemiplegia? That is another. So for all postgraduates who are attending, There is about a list of 13 to 14 differences which have been given, and they are generally asked in the exam. So please know those differences between acquired and congenital hemiplegia. Okay? And then how would you investigate a child? This child?
This child, with the history of previous treated tuberculosis, we would want to examine his CSF once again after baseline hemogram and his LFTs. We would also want to.
So if the CSF, what are you going to look for in the CSF? Which tests are you going to run in the CSF?
CSF protein examination to see if the tubercular meningitis is still if there is still tubercular inflammation which is reflected in the CSF. We could
only for that. Will you not like to look for shunt infections?
We would want to see shunt infection, but this child doesn't give any history of local shunt complications. The tract of the VP shunt throughout is examined normally. There is no redness, induration, or any surface complication on the shunt tract.
Okay.
Besides, the child doesn't come with. The child hasn't presented with any fever. If there is any component of shunt infection, he would have probably presented with a high-grade fever.
Okay. You said this is probably an immune-mediated vasculitic phenomenon. So what will you get on CSF?
We should get a cellular response more neutrophilic than lymphocytic.
Sure. Okay. What else can you do for the CSF?
Ma'am, we can run a CBNAT for tubercular DNA isolation. This child was diagnosed on a CSF CBNAT, which had tested positive for tuberculosis with rifampicin sensitivity. We could redo a CBNAT to see if the tuberculous bacillus can still be isolated from the CSF. And if isolated, its drug sensitivity pattern could also be tested, and it could indicate any conversion to MDR if that is the situation.
Okay, so you're thinking in terms of TB. Any other thing?
Are you isolating bacteria when you're doing gene expert, Sailusha?
No, sir. It could also be a dead bacillus and the DNA. It is
DNA
PCR.
Yeah. You're just looking for a piece of protein, isn't it? So don't use the word isolating. That's a culture. That's a different test.
Sorry.
Do you expect the gene expert to be positive after so many months of steroid and antitubercular therapy? You don't, right?
No, sir. The child has been responding well to treatment. There is documented weight gain, and the compliance is good.
That's the point. So do you really think there's a resurgence of tuberculosis in this case? Because repeatedly you've been talking about TB coming back, TB coming back. Do you really think it is TB? What else? Any other investigation you'd like to say?
First thing you all do with a neurology case, which investigation, even before CSF, you're very happy to do that. What is that?
CT brain.
CT scan, no?
Will you like to do a CT, or you are in the best centers, everything is available? Which one will you like to do? Which radiological investigation will you like to do?
In that case, an MRI and if possible an MR spectroscopy.
Do you want an MR spectroscopy or an MR angiography would be a better choice? Yeah. What is the difference between spectroscopy, angiography, venogram, flare axial?
And spectroscopy differentiates between it gives a protein peak versus a lipid peak.
So for
Angiography would
which group of neurological conditions do you really like to do a MRI spectroscopy?
To differentiate between tubercular meningitis and neurocysticercosis, MR spectroscopy gives useful
Tubercular
information.
meningitis or it's tuberculoma?
Tuberculoma.
Because you must have clear ideas what they are exactly doing. They select a voxel in your MRI and then they find out a peak in that defined territory. So if you are elevated lipid peak, so just don't go with the theoretical things. I'll understand the thing what is exactly they are doing. So if you are elevated lipid peak in that voxel, that suggests it's tuberculosis. That's what we were saying. I think. What are the other indications, madam? We are asking.
So one is differentiation, but nowadays we are not doing that for differentiation. Any other disorder where a lipid profile would be really, really useful for us? Spectroscopy.
Don't stick to this case. Any other cases? What are all the indications of MRS, madam? In pediatric neuro.
What is the DD for tuberculoma? When are you confused that is it a tuberculoma? You said something about neurocysticercosis. So besides that, which are the masses which are close DD for tuberculoma?
A brain abscess.
Yes. Correct.
Any other space occupying lesion like metastasis or
primary brain tumors. And which ones? The posterior foci tumors.
Meningiomas.
Yeah. Okay. And MRI angio?
It would MR angio can maybe give us insight about any vasculitis areas of.
So when you are talking about your first primary diagnosis as immune-mediated vasculitis, will you not like to do an MRI angio first over spectroscopy? Okay. All right. Okay, if you don't have these high-fi things, you have a plain MRI. Can you differentiate between a neurocysticercosis and a tuberculoma on an MR? You don't have spectroscopy.
If we have T2 weighted if there is a T2 weighted MRI available, neurocysticercosis appears as a hyperdense lesion, whereas tuberculoma appears as a hypodense lesion. That is one way of differentiating it over.
Talk about the scoliosis, talk about the loculations, talk about the number, talk about the zone which is more involved.
An Indian person has designed a criteria, Rashikar criteria.
Rashikar criteria.
Can you tell about that?
I'll have to read about Rashikar criteria.
Please read about it.
But neurocysticercosis would have multiple lesions spread over all over the cortex, mostly at the gray matter white matter junction, and tuberculomas typically appear in the posterior fossa at the cerebropontine angles. Scoliosis will be seen in neurocysticercosis, would not be seen in tuberculomas. The perilesional edema is much more in tuberculoma compared to neurocysticercosis.
No, it's the other way around.
It's opposite.
It's the opposite. NCC, neurocysticercosis, has much more perilesional edema than tuberculoma. Okay? Because it's toxin mediated. All right? Okay. All right. So just read out the criteria. But yeah, I think, sir, you can ask some more questions, but Overall, a very good presentation, Salusha.
Yeah, very nice presentation. Just I want to ask two things. You mentioned this autosomal, at least like third degree consanguineous marriage. Is there any relevance in any stroke, pediatric stroke case of third degree consanguinity? Not this case, any other case, stroke, pediatric stroke. What could be in an association?
Commonest?
You asked that history.
Sir, if it is something like a sickle cell disease, which causes microthrombi and can lead to an embolic episode, sickle cell is inherited as an autosomal recessive trait.
Yeah.
Very good.
What else?
What else?
Other prothrombotic conditions like protein C, protein S deficiencies are also inherited as autosomal recessive disorders.
Yes. So around 22, it has been seen in different studies that around 20 to 40% of your pediatric stroke have some underlying prothrombotic disorder. So it's also a thing which you can advise, but not in this case. What are the neurocutaneous syndromes associated with stroke? I think Madam has asked that question, but we not mentioned the syndromes. And which of them are autosomal recessive? Because you are suspecting an autosomal recessive in consanguinity is there, okay? So be prepared with that list always, and you must have those syndromes in your hand.
Okay.
There is one question from Dr. Manoj Patil. Why is the shunt done on the right side and not on the left side?
Nothing like that, just a convenience.
How will you smartly answer this in the exam without hurting the feelings of the examiner? Dr. Manoj might come as your examiner. He's going to ask you that same question. May not be in any books. Presence of mind.
Logical answer, batan.
Yes, logical.
Since
You're
the
done
child
well
is,
in your.
since the child is right-handed, it would probably be easier for him to check the chamber behind his right ear.
Who has to be right-handed, the child or the surgeon?
Surgeon. Where does an individual stand when examining the patient or operating a patient? On the right side or the left side, Shailesh?
On the right side of the patient.
So the shunt will be done at?
On the right side. Will he cross the whole body and put it on the left side? No. Otherwise, you have to be a left-handed surgeon. Isn't it?
So, Sailusha, I had one question. Suppose this child grows up and becomes 25-year-old. The shunt will be short, no? Will you revise the shunt at that time? He's grown, no? From 105 centimeters, the child might go to 160, 70 centimeters. So the shunt will fall short. What will you do? Will you revise it?
In short, when do you revise a shunt?
What is arrested hydrocephalus? So all the three questions have the same answer. Okay, read about it. Read about it. Okay.
What is the commonest organism affecting the shunt? Even shunt ventriculitis or a shunt infection?
Streptococcus.
Streptococcus? Are you sure? You did so well, dear.
What antibiotic do you use? Let me ask you. If you have a shunt infection, what antibiotic will you use?
Rajesh sir, they use that antibiotic any which ways, whether there is a shunt infection or no. It is gram positive or gram negative? Tell us that first. What is there on your skin? What is there on your skin? Skin पर क्या होता है?
Gram positive.
लेकिन organisms Which are the organisms on the skin?
Enough of clues, I think.
Yeah.
Staphylococcus and streptococcus.
हाँ, तो फिर कौन सा जाएगा? शंट उसके नीचे ही बैठा है ना, स्किन के नीचे. So which is the commonest organism?
Staph aureus.
Aureus, ये कौन सा? Where is the location of Staph aureus? Normal location, where can you get Staph aureus normally? So you'll read about the antibiotic strategies, the organisms?
Yes, ma'am.
Okay.
There's one more question from Dr. Sachin Pujari, which is the most common cranial nerve involved in congenital hemiparesis.
It is the seventh nerve, ma'am, facial nerve. Madam had just asked the question.
No. We are saying congenital, not acquired.
Congenital, not acquired.
Congenital में कभी नहीं होता है seventh nerve.
Okay, so whatever answers you were not able to do, then you will read up about them. Okay.
Okay. Over to you, Rajesh sir.
Thank you very much.
Rajesh, Dr. Pragati has looked after Shailusha. So does she have to make any comments? Pragati, are you there?
Yes, ma'am. Yes, ma'am.
You want to add anything?
Sailusha, can you tell how much amount of CSF sample is required for a gene expert, for a positive gene expert? How much sample you require to collect?
Ma'am, at least 1 ml.
1 ml.
How much do you normally send?
For a gene expert sample, we send 0.5 to 1 ml we send.
So then it's never going to come positive, even if it is positive.
Okay, so you will visit the microbiology lab, talk to the person who's doing the gene expert. Okay, there is a protocol written there. Get a Xerox copy of that and put it in the lab and read it every day for the next 1 year. Okay, y'all are doing it day in and out, isn't it? So in that case, you should be able to answer it confidently. Okay.
I had one suggestion, Dr. Sailusha and Dr. Pragati. This was an interesting case. So next time, if you could, record videos of examination of the power and the reflexes, it would be helpful, because the only thing we are missing here is the examination part. I think that would be useful addition. So maybe next time we can do it.
Yes, sir.
All right. So I thank the participants, all the participants, particularly Dr. Sailusha. You have to be very brave to face the people you face today. Okay, Dr. Sampada Madam and Dr. Vinith and Dr. Kinikar, they grilled you, but it is going to be very useful for your examinations. I hope that other participants also learned a lot and they took notes. You can anyways go and view the session again, but my experience is generally people do not. So, write down notes, what questions you don't know, whatever you did not know. Try and find answers to the questions that were asked. And very well presented and very nicely mentored by Dr. Pragati. I once again thank all of you for participating in this activity. We'll see you in on, I think today is 15th, so 29th PGI YCMH will be presenting a case. So we'll meet you at that time. Thank you very much. Thank you all.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you.